and welcome to the next episode on Researcher Revealed. This is the podcast where we go behind just the name that's on a research paper in order to understand more about why they got into research and why are they researching the thing that they are. On today's episode, we have a really unique guest. He is the VP for Research and Development at Optilog, which is a company that has designed and developed a digital intervention aimed to help those who have heart failure and who are elderly manage their illness better. I can't wait to dive in and to find out why he does research. Hello, and welcome to the next episode on Researcher Revealed. On today's episode, we have somebody from Sweden joining us, and I think you are the first guest from Sweden. So say hello to everybody and tell us who you are. To start out with.
Hello, and honored to be here. Thanks for having me. My name is Andreas Blomqvist, born and raised in Stockholm, Sweden, although a lot of people tend to point out that I don't necessarily sound like it. A researcher doing research on physical activity, heart failure at Linköping University. And we decided to do this on site in Lisbon for a heart failure congress.
Yes. Thank you so much, Andreas.
That's a one breath summary.
That's perfect. We're going to go into more details. This is just more like the hi, hello, and then I'm going to dig into who you are, how you got into research a little later. But first off, on Researcher Revealed, we always start off with what I call the Rapid 11. So this is 11 quick questions just to get to know you a little bit and get to know how you work and stuff like that. Don't worry, it's nothing too personal like the size of your waist or anything like that. Just fun and easy questions.
Working on that.
Yeah. Right, so first question. Are you a Windows or a Mac user?
Windows.
Tea or coffee?
Coffee.
When you are writing, do you prefer music or sounds, or does it have to be completely quiet?
Writing text, quiet. Doing analysis, music.
Oh, okay. Interesting. And where do you tend to work, home or office?
Office.
Okay. What time of day are you most productive?
Ooh, as early as possible.
Like, are we talking
5 a.m. 5 a.m.
Okay, we're talking crazy early then.
5, 6, 7.
Okay,
After
cool.
10, I dwindle.
Yeah, I'm a little bit later on than that. Favorite referencing system or manager?
I only know one after I stopped doing copy paste and messing things up in Excel, and that's EndNote. So.
Okay. Well, you're in good company. EndNote is by far so far the most popular one. So you're in
Well, to be fair, it's the one that the university provides for you for free. So, you know.
Yeah. Well, there's like Zotero, which is a free one, which is actually pretty good. I've used that. And then there's Mendeley, which I've never used. I don't know. There's lots of other different ways that people do it. Some people still do it manually, which I'm just like, why?
Yeah, as soon as you change something or update, it's hell. I mean, I did that, and also like in PowerPoint, there's no good system for that, and that's also hell. Like I more often get it wrong than right, so.
Exactly. Right, moving swiftly on. Favorite data visualization tool? So how do you make your figures, graphs, stuff like that?
I hate them all that I've come across. Everything I touch has looked like crap, and I wish somebody could save me from this. I have no good answer.
Okay.
I wish I did. Please tell me what to do.
Okay, fair enough. That's interesting. So far, the one that I'm most jealous, so people tend to use like Visio, which is an MS product, PowerPoint, there's all sorts. What I'll do is maybe in the episode notes for this episode is I'll take the list of the answers for that question so far on everybody else, because it might be useful to lots of other people as well. But there's lots of different options. The one I think I'm the most jealous about, because I've seen its capability, but I don't know how to program in it, is R.
Some of those group plots or trellis plots are very nice to do in R. I think I do most of the plots in R, but I can only get so far, and then I just brute force it into Photoshop and go bonkers on it. But don't tell anyone. I'm not sure that's appropriate. But it's like, what the hell? I can't get the access to do what I want. I'll just put a a white square on top of it and put the words where I wanted to be. So
I do the same thing.
I'm sure we're in good company.
Ah, too funny. Do you snack at your desk? If so, what's your favorite desk
Ah,
snack?
not really. I will drink a lot. I
Okay.
usually have this big glasses of water and ice, and I just squeeze lemon or lime in
Oh,
it, and I sit with that the whole time. So
nice.
that's what I do.
That's a good habit, that. That's a very good habit.
My dentist
Um,
doesn't agree, but
you're what?
the dentist doesn't agree. The combination of both the acidic stuff in the lime
Oh,
and the carbonated drinks, apparently not
ah,
good for me.
yeah, no, that is true. But there's very few things that are nice that are under tickles, but maybe we shouldn't be saying that. See, it's
You
just
know, you,
supposed to
you
be
gotta
health
pick your you gotta
researchers.
pick your poison right. Otherwise, I'd be at the diabetes office. So, it's one of the two.
Exactly. When you're planning and organizing, so whether that's like a layout of a project or a paper or your life, are you digital or are you pen and paper?
Wow. I don't know. Like when I'm thinking and being creative, I
Mm,
always pen and paper. I can't do anything on,
okay.
on that. However, when it's like get serious and I'm actually going to the like let's figure out a project plan and whatnot. I it needs to be in computer and before I'm satisfied,
Yeah,
but my brain is channeled through a pencil.
yeah, yeah. You're the first person who's talked about it that way.
Hmm.
And I would probably tend to agree with you. I tend to do both, but if I'm thinking, it has to be pen and paper.
Yeah, it's the scribbleness. It's like I'm not sure if that's just a matter of who you are as a person or growing up before the other thing was an option.
Exactly. That's what I wonder too. It's a curiosity. There's a
If you keep
product in there.
interviewing people, you'll be able to discern that at some point. You can just put them in two bins and like do a statistical
Oh.
analysis, label them as like pre-post digital revolution era or something like that. How about that?
Hmm.
Let's say before and after, born before after what, 86 or something? I don't know.
Yeah, I'd say probably 86. It got a lot more digital
90,
because when
yeah.
I was in, so similarly, I was born in 78.
Yeah, me too.
There we go.
Good year.
And I started hitting computer stuff in school when I was in high school and started using the computer more. So yeah, around the late 80s, I'd say. Right, two more
Hmm?
questions. What book are you currently reading or listening to?
Oh, well, then this might be divisive already. I'm reading a book called The Coddling of the American Mind by Jonathan Haidt and another friend.
The Coddling of the
The Coddling of
American
the American
Mind.
Mind. It's
Ooh,
he is before I get like dismissed as crazy person, he is a liberal, a professional in the liberal arts of moral psychology. And he
okay.
did a TED talk that I thought was great. And like whenever you meet people with different walks of life or whatever, and you have your conservative and the liberal friends or whatever, you put them in the same place. I always want him to watch Jonathan Haidt's TED talk on conservatism and liberalism, or I mean, by U.S. standards, this would be like left or right in Sweden, or
Yeah, yeah,
conservatism and whatever progressivism. And it's just a yin and yang approach that I think is so cool
yeah.
to that. And he's just he was writing a book about maybe like overprotecting our kids or what effects that has, and also uniform thought and university faculties and such. So very interesting.
That's interesting. So what I do is everybody who gives me that, I put the name of the book and the author in the episode description. So if you're out there and listening to it and you want to read the book, you can check it out in the episode description. And also I'm compiling like what researchers read virtual library at the same time.
I'm just so happy I managed to put the Donald Duck book away in time before you asked the question.
You know what? It's so funny. Like, people get most nervous, I'd say, about this question because they've listened to the podcast and they're like, "Oh, most people are like talking about these really highbrow things." And I'm like,
Uh,
whatever. Like, some people, have got young kids, and so they are reading Donald Duck, and there's
yeah,
nothing
and
wrong with that.
this is one of the things that has some kind of what you call it. There's a right and a wrong answer. You don't want to be the person that doesn't read. I generally don't read. I'm a slow reader. I was never reading a lot growing up, although always being, into the field that we will be talking about, but never was a big reader. And it's usually summertime when I get something. So
Okay.
I enjoy it reasonably well, but
Yeah.
it's also a matter of what, what the rest of your life looks like, I guess.
I was going to say, like, when I was doing my PhD, I went through phases where I needed, like, I call them like brain candy books in order to distract my mind after like all the heavy thinking and work that a PhD caused for you. But pre-PhD, like I was reading like really like classical literature and stuff like that because
Oh
I
man.
enjoyed
Yeah, you
it.
envy those people. Like there's so many points of references that just, goes by you when you're like a
But I think
illiterate like myself.
you are not illiterate.
Wow.
Okay, let's be honest. You're not illiterate. But I think too, like I think that's one of the reasons why I asked the question is I find it a source of inspiration to challenge myself to actually think about like what I'm reading and like you said, it's more I find it interesting when you meet somebody and you hear a book that they're reading, it makes me more attracted to reading that book because it's just about stepping outside of your comfort zones, but the more
Yeah.
you read or listen to, the more that you have different views or your view starts to change and alter. So I think, it's part of the fun.
Yeah, it's good. I haven't read many novels last 20, 25 years or so. It's gotten more and more. Like I read a lot of biographies, either
Yeah.
from like because I'm a big music fan. So the previous book before this was Ozzy Osbourne's memoirs.
Ah,
So
fun.
so I love stuff like that, and otherwise like maybe political or like commenting on
Yeah, yeah, yeah.
social
Yeah,
questions, stuff like that I find
yeah.
interesting.
Yeah.
Mm.
Very cool. Very cool. Right. Last question before we dive into things. Who is a researcher that you admire?
This is yeah, this is fully spontaneous then, but I guess I'm gonna have to like highlight just my chief supervisor, Tini, because what I think that she brings to the table that I find lacking at times, and
Mm-hmm.
probably is the key reason why we gelled so well and work well
Okay.
together, at least from my perspective, is that she doesn't get caught up in the red tape and the formalities, and that she's got a pragmatic attitude and approach that I really, really like. We'll come back to the angle I'm coming at this from. So with me, that just sits really, really well. Also, she just turned 60, so and also a woman, and in that age, and moved into a different country, learned the language, and just created an amazing career. So
Mm.
that's my spontaneous response, I suppose. I think
I
Tina
think
is
that
super cool.
I've only just met her and I totally agree with you. Like I've read her work for ages and always had a little bit of a when you read people's research, or at least I do, I kind of create this character in my head.
Mhm. Yeah.
But the character who was in my head is so different than the character in person. And
Yeah.
how you described her was be exactly how I would describe her. Like she's a
Uh,
real, like really open,
uh,
flexible, pragmatic, and wants to see and move things forward
yeah.
rather than, like you say, being a tick boxer
Mm,
or
mm.
follow the ruler or things like that. So no,
Yeah, and
I think it's a good choice.
she's so colorful, and I mean that both
Mm,
in the literal and the figurative sense that she just lights it up, and I think so. And
yeah.
she writes books like that has nothing to do with research, and
Oh,
that
I didn't know
also
that.
yeah. So that's also something that I think is super cool. I love it when things get mixed up like that. You don't expect it. Like you
Yeah.
see I don't know. You find a I know I can't think of a contest. Like your hairdresser turns out to be champion of clay pigeon shooting or something like
Mm-hmm.
that. Stuff
Mm-hmm.
like that is fun to me. So I mean,
Yeah,
it's
yeah.
just an
No, I agree.
unexpected. So I think
Yeah,
that's cool.
that's very cool.
Speaks to a
Oh,
vast intellect, I think.
yeah, definitely. I'm gonna have to hunt down some of her books. Are they in I'm guessing they're probably either in Swedish or in Dutch, yes?
Oh, I wouldn't know what language she actually writes them in. I mean, her native tongue was even Frisian, which is like a subpart of the
Mm.
Netherlands,
Yeah,
but
yeah,
of course fluent in Dutch. I don't know. I didn't know.
I'm gonna have
I
to do
just know that
some.
she went away on this like writing retreats and stuff. So, and non-scientific literature, it's not something I've read yet. So I don't know, but check it out.
Mm,
Maybe it's cool.
I'm gonna say I'm gonna have to check that out. Quite curious. Right. Thank you very much for those answers. On to the main event. So you said in the introduction you're a health researcher. Now we've met, we've had a couple of conversations, so I know the answer, but share with everybody who's listening out there, um, what kind of health researcher are you, and what is your health or your background? What brought you to health research?
So at least in the university where I'm at the medical faculty in Linköping, I'm definitely uh, the odd one out there. So I got my master's in electrical engineering from
Mm-hmm.
a Royal Institute of Technology, graduated in 2004, starting 99. Um, and majored in telecommunications and digital signal processing.
Okay.
So, and then a woman I knew there, she was 2 years ahead of me. She got a job at a place called Jude Medical. They've
Mm-hmm.
since been acquired by Abbott, but they made implantable devices like
Yeah.
loop recorders, pacemakers, ICD, CRT devices for basically cardiac disease,
Yeah.
implantable devices. And she asked, hey, she called me up. I think it was like April or May. It's like, hey, what did you do? And I was like, well, I just 2 weeks ago handed in my application for graduating. So I was like, oh, good. Did you got something to do? Because we might need a hand here to do some data analysis. So I
Oh.
ended up there, just on a like it was originally supposed to be, I think, 3 or 5 months.
Mm-hmm.
So that was kind of the bridge, the segue into that digital
Mm-hmm.
signal processing, and they had a bunch of, I think it was at that point, bioimpedance data that was recorded, or if it was
Okay.
ECGs, can't really remember it. And I was just so digital filtering that to get some data
Yeah.
points out of
Yeah.
that, and then delivering it to the others. So just on a slip of fate, I just accidentally
Mm.
ended up in medical technology and at the research department.
Okay.
And then and that was April 2004, so 20 years ago this year. And that just, took me out. I'm not sure how much time you want me to elaborate on this answer, but that kind of took me, since I've been doing research had been doing it for about 15 years. I figured, you know, we were going to do this new project at work. It's like, well, this is a like a PhD thesis. So I contacted a couple of different universities around Sweden, and Linköping was just the sweetest option. So I went in there and been doing this the PhD in medicine ever since. So,
Okay, so through your job at St. Jude, you were learning, you were using data signaling analysis and things, and then this project actually came up in work, and you looked at and that were like, "Ah, okay, that could be a PhD." So it was more that you'd had experience around research, around like analyzing different things in order to make sense of them, and you then wanted to do something with that, right?
well, yeah, I mean, in so many words, I guess. I mean, I was at St. Jude for 7 or 8 years, went over to LA and did some work there at the main office. And at that point, I mean, I was primarily planning and conducting preclinical research, some clinical studies too. We did some clinical
Okay.
studies in the UK and in Germany, and preclinical studies in Sweden and the US. So there was that, and we wrote it up and wrote the actual manuscripts and published it. So it was all of those research works really. And then in 2012,
Okay.
I quit St. Jude and started my own company, and we developed this
Oh.
home-based tool for elderly people with heart failure to support
Hmm.
them in their self-care. And
Okay.
then we did a voice of customer. Like this was all, non-academic out in the public sector, private sector, not public, private sector. And we did this interview with a bunch of key opinion leaders. So it's like we got this, and this tool. What else would you like us to put there? And the
Okay.
overwhelming, I mean, non-pharmacological
Yeah,
intervention, and
yeah, yeah.
the overwhelming, or the winner, if you will, was some support for physical activity or exercise. So it's like, okay, so we got to do this. And since we were a small company, and I was kind of responsible for the research, scientific, medical affairs part. Um, to be taken seriously, you need to have those letters in your business card or at the end of your email signature. So I figured, like, we're going to do this. I think it's a good thing, and I was familiar since St. Jude that there's this thing they call it like an industrial PhD. I'm not sure if it translates, but basically means I'm not hired by the university. My company pays my salary, but the university is the body that kind of is responsible for the training and the schooling, if you will, to, they're the
Oh,
ones that sign off on the ethical approvals, and
yeah,
you go through courses. You do everything like
yeah.
everybody else is doing minus the teaching. And then I, with this, like, hey, I want to do a PhD on this, and contact these different universities, went over and talked to a couple of them, and having that Tini Arsman and Anna Stromberg were at Linköping, and they were also willing to do it. That made the decision quite easy. So, and that's how that started. So that was a little bit more detail to it. But it was St. Jude, my own company, and then Linköping.
That's so interesting. So, like, there are so many different routes into a PhD, and it's one of the reasons why I wanted to kind of start this podcast, because I think there's a misconception around, oh, you have to do this or go that way in order to become a PhD.
Right.
There's these personally quite false assumptions that people make around it. So, I love how, like, you actually practically being involved, writing research, using that research to fuel and develop a digital application in the industry, so the private sector, has actually been the bridge that's brought you around to doing a PhD in medicine without any clinical background at all. That is a very unique story, Andreas. That's so cool.
Well,
So,
and
with
it's fun. It's fun. Again, look, I think even though, you raise a few eyebrows, I have been, in the homes of, in the clinic with healthcare professionals for these patients for 20 years. So, I kind of feel like one of y'all, even though technically not. And we've always kind of prided ourselves in this company. It's like, let's not engineer this. We're just going to talk to the healthcare professionals, we're going to talk to the patients and figure out what they need. And then we'll use whatever skill set we may or may not have to try to make that happen. So, but yeah, but of course, then I made sure to study anatomy and physiology and get through all those courses and add those as part of my training. So, I mean, I view PhD as that is going to school. You learn science,
yeah,
so.
yeah, definitely. So what would you say, seeing as you've kind of come at it, like, so a lot of people do their PhDs and then they decide that they're going to go either academic or industry. And like, I've even had some people advising me being like, wait to go to industry, hold off as long as you can because of that potential bias and things like that. So what for you would you say would be the biggest challenge you faced coming from industry driven work and your desire to get those three letters behind your name to give you that credibility to push things even further? What's been your biggest challenge?
Um, so I think that kind of goes back to what I said previously about why I click so well with Tini is that, of course, you know, pragmatism and academia maybe can be at odds with each other. Let's put it like that. So of course there's a bit of frustration. For me personally, though, there was a bit of a, clash of, because I mean, I came in, I was running a company, I was a pretty senior, I've been out in business for a long time, and I
Mm,
was also the one who approached the university. I pretty much knew what I wanted to do. So then that puts you in a different level when
yeah,
you're supposed to go into the yes ma'am, yes professor,
yeah.
and sit in the school bench again. And I meet these professors who are used to having this like kind of trepid, anxious kids, 20 years old, just coming out of school.
Mm.
So there was or a few heated discussions or kerfuffles.
Oh, I love that word.
Yeah, yeah, we use that. Me and my wife, we use that word when we've had a
A
had
kerfuffle.
a something. It was a little
Yeah,
kerfuffle,
it's a kerfuffle.
more so than a fight.
Exactly. No,
An intense,
kerfuffle is a much better word than
yeah, yeah,
fight.
yeah, yeah,
But it also
disagreement.
has more weight to it than like, oh, we've had a heated discussion. I'm like, no, you've had
Yeah,
a
yeah,
kerfuffle.
yeah, it was a kerfuffle. So, that was a bit of a challenge. I kind of knew
Mm,
it, you intellectually know something, but then also if you get frustrated, if you feel you get cornered or whatever, then your natural proclivity or where you're at kind of gets the better of you. So, I think there was a little bit of, I mean, I knew that they knew a bunch of stuff that I didn't do, that I didn't know. And of course, that's one of the reasons. And I was very much looking forward to going to school. Like, I love studying. I also got an MBA, went back to school for a couple of years
Hmm.
at St. Jude to do that, just because I know nothing about this. I can learn. So I love going to school and have no problem humbling myself, I think, for that. But then you also get a little bit cocky, it's like I've been doing research also for 15 years. So, I mean, don't write me off as I don't know anything. And then you find out, okay, maybe I didn't know anything. There's a little bit of that process. I think that was challenging.
Yeah.
Other than that, I don't think of it as any challenging. I think, assuming you have some kind of standards or morals or scientific rigor, and I think coming from even though engineering is different than the working with people in the way that healthcare people would do, you're still kind of like have a little bit of tendency to be square or like that personality type that's kind of
Yeah.
blue and square. So I think that type
It's
of
either on or off in
yeah,
engineering.
and if you have a little bit of that and the process oriented or logics and stuff like that, I
Mm.
think that makes it easier for you to get
Mm.
into to academia and those sciences. Even though, again, like me and Teeny, maybe we're not the best at filling out forms in time and getting them to the administrators. We're working on that. We're coaching each other.
Yeah, but you know what? I'd say that's pretty much a universal rule. In my PhD, I actually had a supervisor, for lots of complicated reason, who we actually labeled as my administrative supervisor. And it was her job to make sure I handed paperwork on
Oh
time.
yeah.
I mean, she helped with other stuff as well, but
Yeah,
that was
yeah.
like her main leading role because I had my other two supervisors were outside of my university. It was a really
Right.
unique situation. And one of my supervisors had a tendency, like I'd go into a supervision meeting with one
Mm.
thesis and come out with 12.
Yeah, yeah, that can spiral out of control. Where was this? Was this in Norway?
No, so that was the University of Southampton.
Okay.
Yeah. So moving on from that, so we've talked about challenges that you've had in coming from industry into that. Um, I think as well your situation of what did you call it? Industry funded PhD?
Yeah, again, only know the Swedish word, which is industridoktorand, I mean, basically that means that you're not an employee, you're not hired by the university on a grant or
Yeah.
funding of that. I still get my salary from, well, it's my own company, so I guess I'm paying myself, but still. Um, so yeah. But aside from that, I mean, you miss a little bit of the collegial cohesiveness or that kind of sense of belonging. Like the other people, they would be on site and campus, go out and have lunch together. I'm kind of remote,
Okay.
and so you're a little bit again like the odd one out for several different reasons. But in terms of the demands on you to publish and to write up stuff and to attend classes and all that, it's all the same. So
Okay.
there's no difference in like the hoops you have to jump through.
And with that, do you get to do your PhD full time, or because of the role that you had in your own company, are you kind of dividing your time?
Right, yeah. So I think the official number is 80%, and then it kind of bopped up
Okay.
and down. And
Yeah.
right, lately it's been 100. During COVID, it was zero for a while. It's for many reasons, but so 80% and the other 20 because this is also like this developing this thing that I'm sure we get to talk a little bit more
Yeah.
about. This project or the thesis, the activities, physical activity support that's what we were going to do in the company anyway. So it's like the actual research is the job I would do
Okay.
anyway. And above and beyond that, of
Ah,
course, the attending the courses and the trainings and stuff like that is something I wouldn't have done at work. But that's why it was such a great overlap. And that's why it
okay.
makes sense to the company to fund that. And then the other 80%,
Yeah.
since it's also small, the other 20%, I'm sorry. Since it's a small company, you wear 50 different hats. And I'm also, janitor, IT support, coffee maker, and general happy guy.
Happy
No,
guy.
yeah. So, somebody has to do that. So, yeah, but 80% has been the
Okay.
agreed upon number that we're financing.
So the reason I asked that is I've actually been finding it really interesting how many people, either doing their PhDs or post PhDs, have got some level of duality around their role, and whether it's like teaching and research or clinical and research, or there's multiple aspects to people, and I just find that interesting that it's like you said about Teeny, is the fact that she does all of this amazing research and leads that research group, but she's also writing non-academic books as well. It's that multifaceted, that more complex individual, and it seems to be sort of a bit of a trait. But my question was going to be, before we move on to talking about your research, which I want to do as well, is being somebody who is non-clinical and who is, your whole role and job was around data signal processing, and then you moved to creating this independent company about this app around supporting people with self-care. Supporting people with heart failure with self-care. Do you think that having more diverse research teams around a given intervention, a given whatever, is that a beneficial thing that you think more research groups should build into it?
The short answer has to be yes. I'm not sure to what, if you recruit based on competency, I'm sure you're going to get diversity to some extent, but of course, probably locked in some kind of silo, at least within, like you mentioned, the background of being within the healthcare profession. In this particular case, I'm almost like flipping it around. Like, did I bring any value here being an engineer? I don't know. I think maybe it made for the research to move on a little faster because we had this little team of engineers at the office that then was kind of, if you're looking at this from the university's perspective, there was a team of engineers that did stuff for free, more or less, in this process. And of course, that made it more efficient. And of course, you come with a little bit of different attitudes. But again, like I said, kind of semi-jokingly, I still feel like this has been my field always. And even though I don't necessarily stick the needle in somebody's arm, since our thing has always been including home visits and clinical studies also with patients, you have that like human connection anyway, and you have to, if I didn't have that, it was like this totally like autistic engineer, that probably would have been a problem or an impediment, and maybe you'd want to keep me out of the hospital room. So I don't know. This was not much of an answer, more like a general rambling. But now I remember the question. Circling back to that, of course, different perspectives are always good, and you can leverage people. Like, you probably attack or address a subject or a topic from different angles, and they can bring some more energy to the table. And also in nursing, where even though in studies it was both like like physicians for training, or doctors and nurses. In nursing, there's I don't know, it's probably in the 90% something of women. So I think just coming in as a guy, an engineer at that, might shake things up a little bit. Makes for new dynamics, I think. And in my experience, probably that leads to better outcomes in terms of quality or ideas or something.
So I would agree with you. The reason why I asked the question is it's something that I actually actively trying to pursue in, like, when I'm thinking about a project and whatnot, is I actually try and find out from like people who are best at what they do, and whether that's engineering, whether that's coding, whether that's fill in the blank. And I feel like by bringing those people together, you're then going to get a project that's a bit more robust, an intervention that's a bit more robust, rather than having a nurse who is got basic computer skills, then trying to understand and inform or hire an engineer who is, like you say, that more like, especially like software engineers, they don't ever leave their screens, and that stereotypical individual, it becomes a real potential space for inefficiencies and misunderstandings to happen. And I think, having people like you who learn that, and that's where I think that duality comes into really, really strong play, because you're then able to talk computer and engineering, but you're also learning to talk human and nursing and medicine. And so you can cross that bridge to help the people who, I'm sure you've met them in the hospital because they exist everywhere. The really clever clinicians who are really great at building like health research, but they don't know how to use WhatsApp. And they're
Yeah.
like, yes, let's do digital intervention. And you're like, how about we start by learning how to use WhatsApp?
Yeah, but I also think it's just also coming in from the outside, you shake up some old truths.
Yeah.
Like right when we were doing the Optilog, which is the tool in the
Yeah.
company that we built, it was all about automatic titration of loop diuretics for heart failure
Mm-hmm.
patients. And like the
Mm-hmm.
first time we talked to her, she was like, "Oh, you can't do that." And then another person in the room, and she was like, "Wow, are you neurotic? Of course we can." And but nobody had done it. It was the simplest thing, and it's what you're telling people to do anyway. This is
Yeah.
just helps them to do what you want them to do. And from our point of view, that was like totally obvious, but nobody was doing it within healthcare. So it's might be obvious something that you're stuck in a mindset might be obvious somebody come from the outside. I think that that's probably the best
Yeah.
example of how that adds value. I mean, for once, I was recruited by my old boss. She was at St. Jude Medical. She had went off to a totally different career. They were going to innovate around like private elevators for the private sectors, like in private homes or lifts. You know what I
Oh,
mean?
okay. Yeah.
Yeah. It's like I don't know anything about that, but they just brought it in as a wild card for an ideation innovation day to
Yeah.
just ask the stupid questions and come and shake, truths that
Yeah.
were like Titanic and nobody would ever question them. So yeah, I think that's more than anything that's what we bring to the table. Of course, you can't just take anybody, I think, because you have to have, like I said, for an engineer, you have to have a little bit of a proclivity towards the human touch and being sociable that way and the caring aspect maybe. And if you were going to take then a nurse or a doctor or somebody out of that context and put them in an engineering context, they need to be, you know, have some of those traits maybe. So it's not too, because otherwise maybe you'll just be misunderstanding each other and you can't advance anyway. But in general, a
Exactly.
good thing. The right people,
Yeah.
sure. Yeah.
Yeah. I love that. Challenging truths. We need to put that on a t-shirt or a mug or something.
Yeah.
Because I think it's exactly true. Like you don't think about like if you're a nurse or if you're an OT or a physio or whatever, or even an electrical engineer, you
Yeah.
don't think about anything other than what you assume to be the truth until
Yeah.
somebody new comes along and is like, guys, how about, and they're like, oh, because
Yeah.
it's just not how you learned in school or what you thought was right or what you thought was the morally correct thing to do or the
Yeah, or only
ethically
like, oh, we've
responsible
always
thing.
only do it that always only done it that way.
Yeah, it's that challenging
Yeah,
that traditionalism of delivering something.
yeah,
So
yeah.
no, I love that. That's really cool. Right. So your PhD, tell us all. What's it about? Who's it on? How are you going to change the world?
Mhm. Yeah, so the company that I started 10 years ago, we developed a home-based tool called Optilog, which is, I guess, technically an app, but we put it on a 10-inch 7-inch tablet and we lock it to that. So the whole thing is CE marked as a medical
Right.
device and we put it in the patient's home.
Ah.
So that already existed. This platform is it's used in some parts of Sweden on a very small level still, but we're hoping to grow it. But anyway, it's in 3 regions and one a private practitioner. And that it's a self-care tool. So it helps, like I said, with changing the loop diuretics, which is a drug that heart failure patients need to maintain
Mm-hmm.
fluid balance in the bodies. And then it's an education system in there that kind of changes itself based on their use of the system and also symptom monitoring. So
Mm-hmm.
that's kind of what's already there. And then, like I said, we wanted to add something to that. And what people were requesting was some kind of support for physical activity, which is also a non-pharmacological intervention that is
Yeah.
efficacious and important for these patients. There's sedentary behavior and physical inactivity dramatically deteriorates prognosis for these
Mm.
guys and gals, so we need to change that. So that was the starting point. Okay, so we're gonna create or devise tool or tools for
Mm-hmm.
for supporting physical activity in the heart failure patients, specifically elderly, but that's just because we were going to use the existing platform as kind of the ground on which to build this.
Okay. Yeah. Yeah.
So it was that was kind of that was a delimited this right from the get-go, and it was of course the one demand that we put that we were going to have to be able to use it in our product to finance it.
Mm-hmm.
And then we just started. We did a lot of first. We did a little screening tool. That was my first paper. We just used one of the questions. And Tini and Anna Strömberg, they developed this European heart failure self-care behavior scale. It's been validated in more language than I can count, probably by now. And you use that to assess self-care behavior in patients. One question there was specifically about the physical activity or exercise. So we wanted to use that one item self-report question to see, can we just
Okay.
label patients as physical active or not, and in
Yeah.
just a screening manner.
Yeah.
And it looks like you probably can. For terrible sensitivity, don't even go there, but the specificity is pretty darn good. And
Okay.
Tina said that's pretty much to be expected, I guess. It's like if you ask people, are you taking your medicines? If they
Yes.
answer yes, you have no idea if they do it or not, because everybody says yes. But if you get the few of them that are honest about it, says, no, I don't, I totally disregard what the doctor says, then chances are they're truthful about that. So
Yeah.
pretty much that was, you boil it down, it sounds so stupidly apparent or obvious. But anyway, that was kind of the outcome of that. If they self-assess themselves as being physically inactive, then with a 92% certainty they
Yeah.
are. So that was one thing. And then we just started the whole co-design of like, what is it then that we want to do? And there were interviews with physiotherapists, occupational therapists, doctors, heart failure nurses, and patients and patient organizations, trying to figure out that for one thing that we decided was we're not going to target, it's not going to be an exercise program tool where we're going to do like on at home exercise. It was going to be, if you look at like a Venn diagram, exercise is a part of physical activity.
Yep.
So every exercise is physical activity, but not all physical activity is exercise.
Yeah.
So we also decided, together with my supervisors, that we're going to target physical activity as the non-exercise part of physical activity.
Okay.
However, without, you can talk at great lengths about this. For my patients who are very sick and very, very elderly and, 92% of the time sedentary, there's less clear delineation or a limit between exercise and physical activity, because like for them to stand up, then all of a sudden they would classify that as exercise. But anyway, so that's what we decided to do. We're going to figure out a way to use this tool that they're already using that has very high adherence or system adherence or compliance. We don't use the word compliance anymore. That's a cultural shift. When I started 20 years ago, it was all about compliance, hitting patients in the head, and we support them in what they want to do. Adherence is still kind of acceptable. But basically, the degree, okay, maybe I'm dense now. I'm too old to take in new input. But anyway, basically the level with which the tool is used.
Yeah.
The frequency of use is very high. So we have that in their place, in their homes. What can we do then? And you did this focus group, and we also try to use this Medical Research Council. It's a UK-based organization, and have put together. I mean, it's kind of daunting when you first look at it, but there's a lot of good stuff in there. And like, if you want to devise any kind of intervention in life science or something like that,
you got to use MRC.
There's just a lot of good stuff in there, and a lot of boxes that if you check those off one by one, chances are you're gonna get more right than you would otherwise. So, but it was a long thing. It took like 3 years, something like that, where we did decide a development process based on that, and some other publications too, trying to be still somewhat pragmatic, and did the iterative scheme with focus groups and co-design and all of that, and came up with an intervention theory that they also suggest, which was like super cool. I love that exercise. It's something that I really took with me. Actually did a class or a course. I attended a course from Wales, I think, called Designing and Evaluating Complex Interventions. And it was a lot of those people were associated with the MRC, and that was great. I really, really love that. Would recommend that course if it's still given to anybody who would dabble in that field. It was really great, and you learn about, like, again, intervention theory, trying to figure out, break down what are the things you're trying to attack and why. What makes you think these are malleable in the first place, and how would you change it? And gives a structured approach to it in a way that I had never worked before, in spite of 15 years in the industry of devising tools and interventions. So that was awesome. So we went through all of that and figured out that, okay, so I mean, I was kind of writing my dissertation right now. I should be able to just, know this by heart. But the mind doth try, but is foggy. But anyway, it's so basically we wanted to be give them something that's super easy. You want to be low, because again, like what we're doing is like basically limit touching any buttons to as close to zero as possible. So we kind of immediately threw any kind of high granularity stuff out the window of like using RPE scales or figuring out what exercise they did or like what activity they did. It was more like, I did some activity, 10 minutes of it. I did another 20 minutes. That's it. A little bit of information to tell them what can be physical activity.
Yeah.
Drinking coffee is not physical activity, but vacuuming is,
Yep. Yeah. Yeah.
etc.
Yeah.
And also then it was an education. It was a week of purposeful education because we made a theoretical model, and it kind of turns out that to get motivation to be physically active, there are some things that need to be acquired first by the
Hmm.
user. You have to make sure that um, they believe that physical activity is good for them in spite of having heart failure. 'Cause
Mm.
still there's a lot of people who think that they should just rest and not elevate their
Hmm.
heart rate and whatnot. So there's that. Then there's the they call it outcome expectancy. And then there's efficacy, self-efficacy. That okay, so I know that these activities are good to do, and then you have to believe that I can actually do them. And then the third step is goal congruence. Okay, so these activities lead to this. I believe I can do the activities that lead to this. Do I want what they lead to? Once those three things are in place, then you're susceptible to be motivated to this. So that's how we kind of devised that education. So
Okay.
try to be very scientific and rigorous about it. And that goes on for a week, and then they can start tracking their physical activity. And then and they can be whatever they want. Like for some person, I mean, some of these guys would be running circles around me when I came there. Others, like they get up with a wheelchair twice a day, you know.
Yeah.
So it's a crazy heterogeneous population. That's also get back to how you can assess that then given that heterogeneity, they just input whatever. So if somebody might be, out walking with poles or doing exercise
Yeah.
in a pool, for another person it would be like, well, you did some leg extensions during commercial break of the
Yeah.
TV.
Yeah.
And that's fine. And they feel encouraged. I can do this. And then they get some feedback on a weekly basis, like, hey, you did this much next week. Do you want a goal for next week? Do you want it to be higher than last week's goals? And get some feedback on that. And
Okay.
that's all there is. And that's so that's what we ended up doing and tested in a small feasibility. Then we did a randomized controlled pilot.
Mm-hmm.
Um, and then a qualitative study in interviewing these guys and gals
Okay.
to see to kind of probe their experience a bit more. And those are the works that went into that. So it was the screening, the development process, lengthy as it was, pilot RCT, and then the qualitative study. So those are the works that I did that kind of go into the thesis as a whole.
Wow, that's so cool. Well done. That sounds amazing.
Well,
So how much
thanks.
of that is published so people can find out more about what you're doing?
Yeah, it was terribly slow. Like it's funny. It's like I think that these four papers that are going to be published 2020 and then 24, 24, 24 because COVID
Ah.
paused everything, and then the
Mm.
development process, like I said, took forever even without COVID. And then the second paper, it was held up at a journal for 14 months. I mean, it was dreadful. I submitted it to 6 journals, I think, so it got rejected 4 or 5 times. And then peer review process was 14 months. And I had to get that published because I couldn't very well publish this like RCT without referencing the development work that was done. So we decided we'll wait for it. We did all the research in the meantime. So it's like as soon as that was published, it's like submit the RCT, and that was rejected at the first journal quite recently and was resubmitted like a couple of weeks ago. So
Okay.
I expect that the third article, the Pilot RCT, will be published or
Yeah.
manuscript will be published this year. Qualitative study is a bit more work to do. We're working on analysis pretty much done, but we're working on writing it up right now. So I expect that to be published later this year. So the first two
Okay.
works are published, and
Nice.
uh, and the RCT sometime later this year, and maybe around the turn of the year for the qualitative paper, something like that.
For everybody who's out there watching or listening, we will link the two publications that are out already around the work that Andreas was describing that he's done on his PhD. So you can find those in the episode description or in the description on the YouTube video, whichever you prefer. And then definitely give him a follow on LinkedIn because I'm sure that as you've just heard him describe, like the battle to get published is quite severe and like when you actually manage it is like room for massive celebration. But I've never like that's crazy. 14 months in peer
Yeah, yeah,
review.
yeah. That was unheard of. Even it baffled a lot of people. I mean,
Yeah.
like I said, I've been doing this for a while, and you're kind of jaded, but that was out of the ordinary. So that
Yeah,
was not
that's
super fun. I mean, that at
no.
least cost me probably an additional 6 months for nothing. But it is what it is.
Yeah, it exactly.
A few more gray hairs, that's all.
So really quickly before we wrap up, because time has flown by and I could honestly talk to you forever because I find your unique perspective really, really interesting when it comes to thinking about digital health and like I think your experience, not just as an electrical engineer, but as a founder of a company that's developing such a thing, I think it adds a really different and much needed aspect to it because I think sometimes for all the reasons that you experience, like having that proper in how I see a lot of digital stuff anyway, is you kind of have mainly two groups. So you have stuff that is developed by researchers who may have varying degrees of computing ability, let's say, but they're clinicians and they want to do better. And those apps take a really long time, and by the time they're published and printed, they're so out of date it's, you're like, well, was that? And then your other major group is like the industry driven apps, which tend to be much more just generic. So, like all of the apps around like tracking your food or tracking your physical activity and all of the wearables and stuff like that. But those, while they're mass market and fast and they've got big teams behind them, they don't necessarily meet the needs of that growing population of people who've got something wrong with them, who need a bit more support. And like you said, with your own group, there's such a wide heterogeneity in that group. How do you make something work for and be encouraging and get people to want to move more when, a hard day for them means they got out of their wheelchair 3 times versus those, and they've got the same health condition, so they both have heart failure, but then you've got somebody else who's hiking, 6 miles a day. So I think you add a really unique perspective, and I'm really looking forward to reading more about your research. But before I let you go, how are you going to deal with the complexity of your sample size?
For a specific study, you mean, or in general?
For your RCT, yeah.
Oh, yeah.
Like the fact that you've got such a wide group of people with very different.
I mean, one of the, I guess, the main conclusion of the pilot RCT is you can't make an efficacy study. It's just like super boring outcome. No, I mean, it's also like we wanted to make sure that in the pilot RCT, we decided that all of the patients were to have the Optilog system before, because otherwise that's such a big confounder, because it's been shown in other studies to influence self-care behavior, and physical activity is one part of self-care behaviors. Otherwise, you would never ever get past anybody commenting on the placebo effect or the other confounding factors. So we had everybody who had already Optilog, and then they were randomized to either getting like a fake version, like we just tried to trick them, it was half blinded, or they got the actual activity coach, as we call it, installed, and then we measured that. And that, of course, as we were a small company, that limits the amount of people you could actually recruit in a full efficacy study. And, we had such a hard time. And, calling up people who are 85 in rural parts of the country, asking them to participate in a study that involves technology and tracking your physical activity, since you probably are physically inactive, that's a bit of an uphill battle, to tell you the truth. Like, I think we had like a 22% recruitment rate and that was after calling each and every one. So that was a dreadful experience. So just goes to show you that, a fully powered efficacy study will be a big battle. Certainly beyond the scope of this thesis, let's put it that way.
So given those challenges that you've just said, do you think that this is even feasible for this population? Are we creating something that nobody will ever use? Are we creating that unswallowable pill?
That's a well-motivated question. I think for the basic device, the science is sound and solid and is being, publicly procured. So that's one thing. And then I think that the physiotherapists and occupational therapists and whoever nursing professional that are kind of inclined or interested of this, they're an underserved group. They have no means at their disposal to work with these patients when they leave their office. So I think that there is at least a scientifically rigorous foundation for what we did. And since the platform is probably going to be picked up anyway, I'm hoping that this will just garner some interest from that professional group, physiotherapists, and like, man, we need to work with these patients and kind of mobilize them in their homes. Maybe this is a good way to do it. And maybe, full-blown RCTs doesn't really matter. This is also not we measured a lot of different parameters, and I don't think necessarily when we're talking about octogenarians or 90-year-old plus patients, maybe with a 50% mortality rate in 3 years in this population, it's not all about the uh, the readmission rate, etc., or the blood pressure. It's
Ooh,
like
now
if
you're getting
these,
controversial.
yeah, because if these people instead, and we had even in this like very small pilot RCT, we had dramatic. It was like 15, 15 over 18% difference in health related quality of life. Great,
Wow.
dramatically significant. Goal attainments achievement through the roof.
Whoa.
So basically what happens is that these people are given meaning, and they're giving us something that they feel that they can do. Finally, I have something in my hands that I can affect and influence, and that has to be important too. And so I think hard outcomes at this point is probably besides the point. I think that any kind of uh, there's a lot of science on physical activity for healthy people. There's a lot of science on exercise for sick people. Physical activity, aside from exercise and sick people, is an empty field. And to look at that and see what kind of hard clinical outcomes, you'd have to look 5, 10 years down the line, at which
Yep.
point all my patients are dead, to
Yep.
be frank. So there has to be different drivers. And I think quality of life, subjective goal attainment, satisfaction, and a positive experience, feeling safe and secure and adding value to your life should be the drivers for that one.
Well, no, I totally agree. And so in the heart failure world, there is a slow movement around trying to look at what should our hard outcomes be.
Mm.
And there's some interesting studies that have said like there's discordance between what patients want and what clinicians want, because
Mm.
clinicians are all about are you alive or dead? And
Mm.
patients are like, I don't care if I'm alive or dead. I just want to be well enough
Yeah.
and happy enough to do things that I value. And I think, what you said, like it is controversial at the minute, because if you're going to have like the best study out there, this RCT or randomized control trial for everybody who
Mm.
might still be learning what all the research acronyms are about, is held up as this holy grail. But then when you really dial down and look at them, what are they looking at? They're looking at a hard outcome of are you alive or dead? Are you in hospital or out of hospital?
Mm. Mm.
And, you can't stop death.
No, no, somebody can always question the follow-up time. Did you follow up long enough? Where you follow up long enough, everybody's dead. Then there's no difference. Like when you stop,
Exactly.
it's a bit arbitrary, and I think that's something that's really that. I mean, there's been a lot of discussions about like p-values, or a lot, some at least, the last 10
Yeah.
years, which I think has been healthy. And
Yeah.
I think we need to have a similar discussions about these like outcomes. Like it's also arbitrary. Who
Yeah.
says that after 3 years we stop looking? Look, 10 years, then there's no difference.
Yeah.
Everybody's dead. Look, 6 months, there's no difference. Well, so what are we looking at and why?
Yeah.
It's just again, it's the status quo there, and I think also one thing, if I just may slip that in there as well, I think that there's a little bit. I've for me, it's been frustrating working in med tech for 20 years, especially among the healthcare professionals, if I may say so, especially doctors, but also academic nurses, um, that everybody's used to sample sizes from pharmacological, pivotal IDE stage 3 trials where they expect to see 14,000 people. And the reasons for that is, well, A, they're looking at effect sizes, absolutely, effect sizes of like 1 or 0.1%,
Yeah.
and they're looking for side effects that manifest in one of 5,000 people, and they need enough to make a judgment
Yeah.
based on that. Whereas a med tech, you might not have any side effect to talk about, and you're looking at effect sizes of 25%. It's
Yeah.
perfectly appropriate to have an
Yeah.
RCT of 200 people.
Yeah.
So there's also those worlds that don't really mix. So I thinking about study design and output, there's a lot
Yeah.
that can be improved, I think, in the scientific
Yeah.
community there. Kind of on a
Yeah.
tangent to what you said, but anyway.
No, no, no. It totally is aligning with what I was saying, because that's, to me, I think that's something that as non-pharmaceutical researchers, let's say, um, it's one of the biggest criticisms that research get slated with. And again, I don't think it's completely justifiable for the reasons that you just said. And also within the world of heart failure, I listened to Milton Packer. So he's like one of the medic researchers from America when it comes to heart failure. And he did like a history of research and how much has changed because of all of the different medications that have been added to the treatment schedules of patients. And he actually said in a talk, which I thought was very insightful and really, really interesting. He's like, because we've now stacked benefit after benefit after benefit, we have improved things when it comes to those hard endpoints of mortality so much that in order to move the needle a little bit, you then have to have these massive like sample sizes, because the chances of being able to again stop death from happening are getting smaller and smaller and smaller. So to move the needle takes a lot more work. And it goes back to that whole thing, you know, if you're already semi-fit, it becomes a lot harder to get fitter, where if you're really unfit, it doesn't take much to move that needle. And it's not a linear relationship. It's a bit of a more complicated relationship. And so having those different outputs as being important things, and having the acceptance of RCT in a med tech, especially in digital intervention, that's got, you know, 200 to 300 people in it, and like you've done, really robustly designed, using the frameworks, using theory in order to inform that design, that's going to stand on its own two legs, personally.
Yeah. We'll see where it goes.
We'll see. So my last question before I run away, because I just looked at the time and I'm like, what? I'm guessing your app is Swedish only? What are your plans for upscaling? Because you mentioned that as a limiting factor. So how do you plan on changing that, given it's this platform that you're actually founding member of the company that delivers it and creates it?
So it's translated to English, German, and Finnish already, but it's still only on the Swedish market. And that's, you know, it's a classic, takes money to make money. It's just a lot of money to get into a new market. And we just have to build enough traction, I think, or enough momentum here to be able to to make that happen. But I mean, it's in the pipe, of course, as you know, is adding more features and possibly new diagnoses. I think there's a lot of exciting stuff to be done about heart rate, or potentially also titrating beta blockers or something, you know, you could look into. A lot of interesting stuff that can be done. Basically, I think, again, on a philosophical note, where I think that we might be going in a direction that I don't think is super conducive to efficient healthcare. And that is, just because you can measure something doesn't necessarily mean you should. And when we are, I mean, in the future where AI is much more sophisticated and trustworthy, things might be different. But looking today, nobody, I've talked to people all over the world, nobody who's a clinician today wants to see 3 blood pressure readings a day from stable ambulatory class 2 NYHA class 2 patients in their mid-60s. It has no clinical relevance. And instead, you get the patients to burden the patients with this, you get them stressed, you get them pacified because somebody else is monitoring their health status, and you turn clinicians with, you know, whereas heart failure nurses who are specialized in this, and they sit there and sift through data points for no apparent reason. It's like, oh, this is a weird measuring. Then we might have to track this patient down, spend resources on that, trying to call the patient, get him or her to pick up the phone, and then ask what happened. Oh, no, I was probably just trembling when I did the measurement. Okay, back to work again. This is not efficient. I mean, there are definitely situations where you want to get some vital parameters from a patient in a certain situation, hands down. Also, the ability to connect so you don't have to get him exposed to disease or contagion at the emergency ward. Beautiful. Awesome. But the big ambulatory stable mass, well, we need to just close the loop in the patient's home. And that's really where you need to, there is room for improvement there. There's a lot that can happen there. And I think that's where I see the future. For us, at least, I want to not contribute to sending chunks of unfiltered data upstream to an already bogged down healthcare organization,
Yep.
but enable the patients and make them be an active part of the healthcare organization. I think that's where we as a society and a patient stand to benefit the most.
I love that. Preaching to the choir. Anyway, last question before I let you run away. What would be your top tips to somebody who might be like yourself, a little bit of, I'll use your words, oddball, in that you're doing health research as a non-healthcare clinician? What would your advice be to another electrical engineer or computer technologist or software engineer or hardware engineer out there that you're like, why should somebody else do this?
If you have the least bit of interest in life science or physiology or anatomy or disease or health or people or anything, then that's enough. Then you should just reach out to anybody and go for it. Because like you guys are hard to come by. They'd be happy to have an engineer come knock on the door. Go for it.
Beautiful. I love it. I love it. Thank you so much, Andreas, for your time. I've thoroughly enjoyed getting to know you a little bit better, hearing about your story and hearing more about your research. I did read your two existing papers and I really liked them, so I can't wait to see the next ones that are in the pipeline. For everybody out there who's listening, if you've enjoyed this episode, whether you're listening to it on a podcasting platform or whether you're watching it on YouTube, use the YouTube comment section if you have any questions or you want to have me ask Andrea something more, something you need being clarified. That's just the best place for me to find it out rather than to having to hunt all through social media to get any further questions. That's it for this episode. Thank you so much for listening, and I will see you all again in 3 weeks. Bye. Don't go away. Up next, we have the top 3 takeaways from this week's podcast by Dr. Rosalind Austin. As Andreas said at the beginning of that podcast, we agreed to have a further conversation. He was one of the very kind individuals at the Heart Failure Association Congress in Lisbon, who was a part of the video that I did of talking to loads of different people who do heart failure research. But we'd actually met before then. We met at International Research Week that Tini Jarsma and Anna Stromberg had put on at Linköping University. And it was there that I first heard him start to talk about, one, his background and how he was integrating that very electrical engineering background and knowledge together with theory to come up with a real practical solution for people who have heart failure. And I really wanted to dive into that more. And I'm so glad that I did. He's was such an interesting journey, and how he developed his life and his career and how he's gotten into research and sort of his motivation behind that research. Being that the company that he started, who's created this application, you know, he's recognized and has lived and worked in that research world enough that he knows the strength and the added bonus that having a PhD will bring to you within the field of research. And so he wanted to pursue that. And I hadn't heard of what how he's doing that ever before. So I think for me, that's the top takeaway. We've had multiple guests now on the podcast, and pretty much everybody has had a slightly different way of how they've funded or got into their PhD. But his being industry funded PhD, that was the first time I'd ever heard of that. And there's even like a specific word for it in Swedish. It was a really interesting way of entering into it, and whether or not there'll be more and more of that happening, especially as more healthcare and more industry partners want to develop into this area of digital health and mobile health applications. So it was really interesting to hear. And even though he has an industry funded PhD, he still is like many other guests on this podcast, where he's still doing that other job as well. As it's 80-20 split, and it probably fluctuates a bit, but you know, he's in some ways he's like an industry academic maybe, so making the definition of who a researcher is even more broad. So yeah, that was my top takeaway. is that there are so many ways to make a PhD happen. And it's more like what he said, like if you give something to bring to the party, then bring it to the party and give it a try. Right. My second takeaway is the added value that having somebody who's from a completely different walk of life can bring to your research project. And it's something we've touched on previous episodes, but not to the extent in this one. And I thought his phrase of how he feels that by being an electrical engineer who's coming in and who's educating himself on things like anatomy and physiology and illness and whatnot, so that he can understand that other perspective and speak that language of the other perspective. But he felt that he's more willing to challenge what those clinicians have accepted as truth. And I thought that was a really interesting way of looking at it, is rather than, bringing in that additional perspective, which is part of it. He's like, it's that fresh look, that willingness to challenge what somebody might have conceived as being the truth, but is actually maybe just the way we've always done it. So yeah, be brave enough to invite other perspectives from different walks of life into your research so that they'll help you challenge your own truths. Finally, because this is going to be quite a long episode, I think. Oh, I could have talked to him forever. He was so interesting to listen to. It was closer to the end of the podcast, is his question of, does an RCT really matter, and what makes an RCT matter? And I think that's a really, really good thing to think about, is especially as non-industry or pharmaceutical industry research study, and especially with nurses, a lot of digital health studies, occupational therapy studies, physiotherapies, non-medic research. The numbers who are included, so how many people participate in the study, are often substantially smaller than like what a big drug study was. And we kind of dove into that a little bit. And I think it's a really important thing, like when you're first starting out in research, the biggest, most powerful studies that people talk about are like the really big meta-analysis and meta-syntheses, but also directly under that, in that hierarchy of evidence, is that randomized control trial. And everybody holds it up like this holy grail of you don't know whether or not something works until you've done an RCT. And he's not necessarily challenging that, but he's questioning that. And I think he raised some really good points that have been being asked in the heart failure circles of what are the important outcomes? Is it whether or not you die, or is it how well you live your life while you still have it? And I think those are really, really important things for us as we start to design more and more studies as non-medic researchers, is to really carefully consider what is the question we're asking and what is the actual appropriate research design, and what do the elements of that design look like in order for it to become meaningful, powerful, and not just to those other researchers who we want to read it, but to those people who we're serving as researchers. And I really appreciated his perspective on that. So definitely my top takeaway is, does that RCT really matter, and what are the outcomes in that? What are the elements of the RCT that really matter? That's it. Thank you so much for listening and following along and subscribing to the podcast. Just after I had stopped recording the episode, and he was saying to me afterwards, and he did give me permission to quote it, so I hope he'll back me up on this by putting in comments under when we put this podcast out, is he thanked me for the work that I'm doing and trying to make research and researchers more accessible to everybody else. And that meant the world to me. And he's not the only one who's done that. A lot of people have been reaching out to me privately, and it really means a lot to me, because it's one of the many reasons why I started this podcast. So I hope you enjoy. If you do have questions, if you have want to find more out about Andreas, all of the details around how to find him, the studies that he's published, his company, things like that will all be listed in the episode description. If your questions aren't answered by looking at that and you do have a direct question, drop a question in the YouTube comment section, because that's the easiest place for me to find and filter, and I can forward them on to them and on to Andreas, and he'll then be able to go from there. Thanks again for listening and for all the likes, comments, and sharing of this podcast. I will see you all again in another 3 weeks for another great episode. Until then, keep asking why.